Good morning, everyone. So I'll be talking about how to interpret a normal retinal OCT and what are the features that we can see. So OCT, we know we are able to get the different images because of the varying degrees of reflections from the different retinal layers. So whenever we are doing an OCT interpretation, we do two types of analysis. One is a qualitative analysis and one is a quantitative analysis. In the qualitative analysis, we do an overall study of the morphology of the layers, any changes, and we look at the reflectivity patterns. And in the quantitative analysis, we look at the overall, the thickness and volume of the layers. So these are some of the lines and the scans that are done. The line scan would show in a vertical and a horizontal meridian only, but then this may sometimes miss out some lesions which are not in those meridians. So the preferred ones are raster and radial. Raster has got a series of parallel lines of high resolution, and radial is 360 degree but centered at the fovea. So these are some of the fine, you can see, pathologies which are picked up by raster or radial, but which may be missed otherwise. So how does a fovea look at? At a normal retinal scan, a fovea would appear as a depression like this. And we are able to see all the layers very clearly because the interior boundary, that is the RNFL layer, is highly reflective, and the posterior most layer, that is the RP, is also very highly reflective. So this is the various layers, just a correlation, various layers in the scan. And this is the histopathologic correlation. Now, many times you will see a colored image. So what do these colors represent? They are false colors, they're not true. So what do they represent? The layers with very high reflectivity, they will appear as orange or red. So this includes the RP layer, the RNFL layer. While the layers with medium reflectivity, they will appear in different shades of green, like the plexiform layer, the external limiting membrane, ISOS layer. And the layers with least reflectivity, they would appear shades of blue, like the nuclear layers, the ISOS, and vitreous, of course, there's no reflectivity, so it appears as black. Now, whenever we are evaluating OCT images, so we have to go, first of all, look at the quality of the scan, then the position of the scan, and then we carry out the assessment. In the quality, we have to first see, are we getting both the inner and the outer band? What about the signal-noise ratio, any shadowing effects, and any abnormal profiles? So first of all, in the quality, see the first picture, you are seeing two areas where you are not able to see the interior and posterior band. But this is not due to any pathology, but because of the shadowing effect of the thick membrane in front. And in the second picture, you will see, this pointer is not working well actually. It's very weak. Anyway, so second picture, you'll see overall there's a more noise ratio. This is because of any media opacity like a cataract. Sometimes you may see certain things there, but which are not really true abnormalities, but just an artifact. So like in the first picture, you see a gap there, but that is due to a blink. And in the second, you are seeing some wavy structure, but that is due to the movement of the eye. So how do you differentiate from a actual pathology? So first of all, you always have to correlate clinically. And if you feel that it is not correlating, then you always repeat the scan. Next comes the position. So are we actually centered on the fovea? That is very important. So always look for the foveal depression. If it is not there, ask the patient to fix again. If there is low vision in that eye, fix with the other eye on an external fixation. Or otherwise, we can manually try and shift the scan. Sorry, this is just running ahead. Okay. It's running ahead. Can you please 1 minute, can you just... yeah. Okay. So, I don't know, it's just running ahead in between. Okay. Okay, sorry. So now coming to the actual assessment of the layers, we have divided into different regions: pre-retinal, epiretinal, intraretinal, subretinal, and sub-RP. So these are, again it's running off. So these are the regions, okay? So this is how you see them. And these are the terms that you will use to actually describe the changes in the various layers, like irregularity, depression, elevation, fragmentation. So coming to first region, that's a pre-retinal region. It's a vitreous. There's no reflectivity, so it is a black area. But sometimes you may see some abnormal hyperreflectivity patterns. Like in the first picture, you'll see two membranes there. And in the second picture, you are seeing a diffuse kind of hyperreflectivity, which would be due to any vitreous opacity like a hemorrhage or an exudate. Second comes the epiretinal area. This is the vitreous and retinal interface, which is very highly regular, smooth, and reflective. But at times, it may show irregularity. You can see in the second picture is highly irregular. These are some of the changes that you can see there. The first one, you see a membrane attaching. This is called vitreomacular adhesion. And if this membrane leads to traction, then it becomes VMT, vitreomacular traction. In the third picture, you're seeing the whole of retina is being lifted up because of the traction. And in the last, actually, this patient actually had an NVE very close to the fovea. So on the scan, it appeared like this, an alteration of the foveal contour. Now coming to the intraretinal changes. So in this, the main thing that we have to look at is the reflectivity patterns, hypo or hyperreflectivity. Then we look at the shadowing, thickening and thinning, and ultimately the integrity of the layers. In hyperreflectivity, usually we'll see black spaces, and it means fluid. But all black spaces won't be fluid. So if it is a diffuse pattern, then it is diffuse edema. Or you may get cystic spaces like this, so this is cystic edema. But like I said, all are not fluid. So like sometimes, again, it is running off. So at times you may see, hyporeflective spaces like this, but this is due to atrophy of the retinal cells. So how do you differentiate? You'll have to correlate clinically. Now coming to hyperreflectivity. So like here you see hyperreflective lesion here in the outer retina. Similarly here, hyperreflective lesion in the outer retina. Sometimes you may see very intensely hyperreflective lesions, and these will cause a shadowing effect. Then we come to the integrity of the retinal layers. Are they all present? So like in the first picture you see there's a complete loss of all the retinal layers in the center. And sometimes you may have a partial loss of retinal layers like this. Next comes the subretinal and sub-RP region. Here again the hyperreflectivity pattern is very important, and especially in relation to the RP layer. So if the fluid is above the RP layer, then it becomes a subretinal fluid. And if it is below the RP layer, then it becomes a pigment epithelial detachment. So this case has both subretinal as well as a BED fluid. Now RP layer is very important because in many cases that's the layer which is actually going to tell you what is the possible diagnosis. So I'm again emphasizing the terms that you're going to use to describe the changes. So these are some of the changes. You may see undulation, elevation, thickening, fragmentation. So this is what you're going to see. Okay. So just a brief example. Now here the patient has SRF as well as cystic edema. Another case, you have similar cystic edema, but look at the RP layer here and look at the RP layer here. So you see here it is undulated and irregular, showing that these two are not the same condition. Another example, you see subretinal fluid here, similar subretinal fluid here, but are they the same? No. See the RP layer here, there's a PED as well as undulated, indicating that these two are again of different etiology. Now here I would like, when we are focusing on this part, I would like to focus on the outer layer, the external limiting membrane and the ISOS junction. These are very important because the integrity of these layers indicates the visual prognosis. So wherever they are intact, you know you're going to have a good visual prognosis, but wherever there is a loss in the central foveal, subfoveal region, you know the prognosis is very poor. Drill is another terminology. Here, that was in the outer layers. Here, the disorganization is of inner retinal layers. So here you cannot differentiate. You can differentiate the layers here, you cannot differentiate here. Again, this is an important visual prognostication. It tells low visual outcome, even if the edema resolves. So this is a case example, edema has resolved, but because there is drill here, the vision has not improved. So coming to ultimately quantitative analysis, this gives an overall idea of the thickness and the volume of the layers, and this is how we keep mapping and following the response to treatment. So finally, you should know always your anatomy well, you should know which are the OCT features, do a systematic approach, and always correlate clinically. Thank you. The next. Unfortunately, Dr. Talwar, our chief coordinator, could not come here this time, so I will be presenting his presentation. Of course, he is an icon and I cannot even hope to attempt to fill his shoes, but I'll just do my best. So till now, I had described the changes which we can see in OCT in retinal diseases. Now we'll be talking of specific diseases and what all features we can see in the common diseases. So OCT we know for diagnosis, for treatment, for follow-up, and for prognostication. So one of the common AMD. So in AMD, dry type and exudative type. In the dry type, like I said, we will see these kind of undulated RP. And in more advanced cases, in geographic atrophy, you will see loss and disruption of the external limiting membrane, of the ISOS junction, and the outer plexiform and nuclear layer. In exudative type, 3 types are there. Type 1, which is the CNVM is under the RP. So here you will see a PED with some subretinal fluid. Type 2, where the NVE is, CNVM is above the RP. So here you are seeing the hyperreflective lesion in the outer retinal layers. And type 3, which is basically RAP lesion. So here you will see the lesion extending from the retina going into the choroid at times. So at times, not always, but at times you can see it very clearly. So OCT is very important in follow-up and seeing the outcome. So post the treatment in CNVM, usually as it regresses, we will have hypertrophy of RP and the scar formation. That's when we know that it has regressed. Occult CNVM, here we would get usually a picture like this with a PED with subretinal fluid, and once it is regressed, then we keep a patient on serial monitoring, and as and when we get a recurrence of fresh fluid, then we again treat. One term I would like here to mention is RPE rip. So at times when we have a very big bullous tense PED, there can be a rip of RP here, like you see your RP rip here, and patient will come with sudden vision loss, and usually it has a very poor visual outcome. At times you may see a change like this, outer retinal tubulations, which is a sign of severe degenerative changes. Now coming to another common entity, CSR. Here you will have subretinal fluid, but at times you may see a small PED, which is the site of actually the leak in the FA. In chronic CSR, similar you will have CSR, but as SRF, but you will also see these kind of this irregularity here. This is called the brush border sign. This is due to accumulation of waste products in the outer photoreceptor layer and the outer retinal layers. In chronic CSR, you may also see another finding, that is increased thickness of the choroidal layer. This is seen on a modality that is the EDI, enhanced depth imaging. Another entity, this is a dome-shaped maculopathy, which is usually seen in high myopia. In advanced cases, we may see subretinal fluid in this. Coming to PCV, which is again a variant of AMD. Now here we have very characteristic OCT features. You may have a double layer sign, and you may have this tomographic notch sign, which is tall PEDs. So like you can see here, tall peaked PEDs along with this double layer sign. Double layer sign is where you have undulated RP separated from underlying Brooks membrane. Otherwise, you would not see a separate Brooks membrane from the undulated RP. So this is a double layer sign along with the tall peak PED, is very characteristic of PCV. You can also have these kind of features. You can have multilobulated PEDs, or you can have a notch in PED resembling a M. Important differential diagnosis from AMD would be adult vitiliform degeneration. Here you would get a similar kind of lesion, but see on the OCT you get a uniform amorphous material sub-RP deposit. So this differentiates it from a PED. Juxtafoveal telangiectasia, another macular degeneration. You will get similar, these kind of hyporeflective spaces, but like I mentioned earlier, these are atrophic spaces and not really fluid per se. So just mentioning briefly OCT pictures in some common diseases, ERM causing blunting of the foveal contour. This is a full thickness macular hole. And here OCT is very useful in calculating the prognosis. So this is a whole form factor. So if the hole size is smaller, you have much better chance of closure and visual improvement. But if it is more, then larger, then the chances are less. Many times post-cataract surgery, you may be finding patient having blurring of vision and not getting good vision. So this is where OCT is very useful in finding out these kind of cystic spaces in the retina. So this is the cystoid macular edema, and OCT is very useful in monitoring the resolution of that with treatment. Now coming to OCT in retinal vascular disorders, occlusions, arterial occlusion and venous occlusion. In CRAO, you would, this is again a very specific pathognomonic sign, complete opacification of the inner retinal layers, not the outer retinal layers, only inner retinal layers. And this will resolve as the condition resolves. Coming to venous occlusion, in central retinal vein occlusion, you'll have central increased macular thickness with subretinal fluid and multiple cystic spaces, which of course resolves with treatment. In BRVO, you would have similar this kind of cystic edema, but also diffuse edema. But one very specific character is that it is only on one side of the fovea. So it does not cross a midline. So this is again pathognomonic of BRVO. So you see edema on one side of the fovea, you are sure that this is BRVO. Now coming to one of the very common conditions, diabetic macular edema. Again, OCT here, very, very important tool. There are some very important OCT biomarkers in diabetic maculopathy. So this you should know: drill, subretinal fluid, intraretinal cystic changes, ISOS junction integrity, and the hyperreflective retinal spots. Now coming to intraretinal cystic spaces, now these are classified based on size: small less than 100 microns and giant more than 200 microns. And large cysts usually have poor prognosis because they're in the outer nuclear layer and the late stage of DME, and they cause much more damage in the visual function. So this is the patient showing, so they don't respond that well to treatment, and even with steroids they will show a partial resolution. Coming to SRF, now this usually in some studies it has been shown, like Restore and Write, that presence of SRF actually is an indicator of better visual gain in the long run. So this is just a patient showing a resolution of edema with treatment, anti-VEGF injections. Mentioning again drill here, the disorganization of the inner retinal layers. Presence of that in the center 1 millimeters, that is 1000 microns, and disorganization of more than 50% indicates a worse visual prognosis. But in the early stages, drill could be reversible, and in this case, drill is here mostly because of the pressure effect of a adjacent cystic space. So that's why early resolution and treatment of edema is very important, so that drill does not become chronic. There are some OCT biomarkers which indicate better visual outcome in DME. One is presence of SRF, absence of hyperreflective spots, and integrity of the ISOS layer. Hyperreflective spots, these are usually a sign of inflammation. Higher the number, we know we are going to have early recurrence of DME, and they may respond a little better to corticosteroid implants rather than anti-VEGF. So this is just example of a patient where with reflective spots where it has not, responded a little with the treatment. Again, just an illustration, this patient has intact ISOS junction, so we expect a better visual gain. Here the ISOS junction is disrupted, so we know that the visual gain is not going to be good. Finally, the overall thickness map, which helps us in monitoring the progression of disease. One more, just sometimes you may see these kind of bridging retinal processes, and these are actually residual neural elements connecting the inner and the outer retina, and they show improved visual acuity after treatment. So that's it. Just briefly, we have given some features of common retinal diseases. Thank you.
Thanks, Dr.